Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
and this is the Real Health and Weight Loss Podcast.
Hello, lovelies. We are super excited to be bringing you this series in menopause where we're interviewing guests on their expert subject regarding peri-menopause, menopause and beyond. As always, any information in this podcast is just considered general advice, and we would urge you to seek medical attention if you have any concerns about your health. If you're interested in exploring the symptoms of menopause or peri-menopause, we have a checklist which you can download at our website, rlmedicine.com/checklist, or as always, you can click the link in the show notes. Thanks, lovelies. Enjoy this series. Good morning, my beautiful friend. How are you today? I am without Dr. Mary, as sometimes I am. As you know, we have guests from time to time, and I have a cracker of a guest this morning. I think that you will learn so much about things that we don't talk enough about. And of course, as you know, we have been chatting quite a lot about menopause and perimenopause, but I'm here to tell you, as is my guest, that it is way more than just a hot flush or two. I am pleased to introduce to you Dr. Sunita Chelva. She is a legend. She's got her own specific perimenopause and menopause clinic over in WA called Hera, which I love, like opposite of hero, but Hera, and is an absolute wealth of information. So, Sunita, welcome to the podcast.
Thank you so much for having me, Lucy. It's a real honour. I've been enjoying listening to your podcast and I've learnt a lot myself, actually. So thank you.
Oh, excellent. Thank you. Well, as we were talking off air, we know, and we've been doing this menopause series to sort of bring home the fact that menopause is more than hot flushes. And whilst hot flushes are annoying and inconvenient and can certainly impact a woman's life, there is a whole heap of other things that we're not talking about necessarily. And so it's time for us to shine a bit of a light on it. And I'm super interested to hear your thoughts, particularly around the musculoskeletal system.
Yes, I know. Now, it's something I think that, we know that bones, Lucy, and muscles are a framework of our body, but without them, we would be a quivering pile of jelly. I mean, they're not just for support and structure and movement, but they've got many other functions that we don't really think about. So mineral storage, blood production in the case of bones, metabolism in the case of muscles. And we don't really pay attention to our muscles and bones when we're younger, do we? Because, it's not until we actually injure something that they generate pain and we go, oh, that's inconvenient. Mobility is really a gift that we take for granted until we actually lose it, I believe. So we know at menopause, as we talked about, there's this seismic shift in physiology with this reduction in estrogen, progesterone and testosterone. And this has quite an impact on our bones and muscles. And women suddenly notice, it's almost overnight, that they can wake up with terrible aches and pains and stiffness. And my patients often come in saying, gosh, I feel like an 80-year-old woman. I'm 45 and I feel horrendous. It's actually, you talked about hot flushes and night sweats and things. That's what we all know. But musculoskeletal issues are actually one of the most common complaints and least talked about. I see it with women who are, not just sedentary, as often happens at this stage of life, but even the ones who are actually great exercisers, the ones who've always had good habits. And they find this very distressing, particularly with the limitations of their movements. They're suddenly not being able to do what they used to be able to do. And that's, that really is impactful on someone's life.
Absolutely. So what I'm hearing from you is that there is like almost two components to the whole musculoskeletal issues, the things that happen immediately and then the things that go on to happen as we age and progress if we don't do anything about it for the future. Have I got that right?
Absolutely. It's a different trajectory for everybody. That's the interesting thing. And I guess it all depends on your individual experience of menopause. It's very different for different women. And, menopause is one day, seemingly. It's an arbitrary scientific thing that we've conjured up to say on this day, you've 12 months after your last period, you've thrown out your last egg, all your hormones are rock bottom. But through, 4 months to 10 years before, through perimenopause, things are starting to fluctuate. On average, they are reducing. So, a lot of the things that are here, patients have been to many doctors, many specialists and other allied health before they've come to see us, and no one's actually validated them for the fact that perhaps you are actually perimenopausal, you're losing your hormones, and therefore, because we know that all these hormones impact every single cell in our body, that your symptoms are probably due to that. And so there's this new terminology you may have heard about, the musculoskeletal syndrome of the menopause. It's recently been coined, and I think it's a great umbrella term for what happens to our muscles and bones at this time. Things like back pain, plantar fasciitis, hip and shoulder bursitis, and frozen shoulder often seem to cluster around this time of menopause as well. And, we see increasing diagnoses of inflammatory arthritis and fibromyalgia. And a recent study has shown that up to 70% of menopausal women have musculoskeletal symptoms, and 25% of them have disabling ones at that. And so frustratingly for clinician and patient alike, some of these pain syndromes don't correlate with any of the findings that we see on radiological imaging. I actually have a lot of compassion for patients who come in complaining of severe joints, aches and pains, because actually part of my own menopause journey landed me at the rheumatologist with a diagnosis of seronegative inflammatory arthritis. I know you personally understand this very much as well. I remember feeling so sore, Lucy, bone weary, weak. I remember carrying this pot of boiling water from the stove across to the sink, and I didn't make it. And I spilt it all over the floor, and it was during a dinner party, and it was very embarrassing. I was put on methotrexate for years. My hair was starting to fall out. I wasn't feeling better. I went through early menopause, and I'd already started HRT at this point. But after quite a bit of research, I realised a few things. Probably I wasn't on an optimal dose of estrogen. Increasing it actually helped a bit. The other thing that struck me was that my gut health wasn't very good. Muscle loss definitely was contributing. So addressing these things meant actually that I didn't have inflammatory arthritis at all, but musculoskeletal syndrome of the menopause looking back. And I often see this same inflammatory picture coming in through the door with my perimenopausal and menopausal women. We know that estrogen particularly has a very anti-inflammatory effect on the body. And it's a really hard thing for doctors to differentiate, because currently with aging, there's also the risk of autoimmune diseases like rheumatoid arthritis or inflammatory arthritis increase. So they can absolutely still be present in tandem, and they also need to be managed accordingly. So we can't just say, here's some HRT, it's all going to get better. We actually need to tease out these symptoms and see what's actually going on here. So that's part of what we do in a consultation, but it's a really common presentation for sure.
I think it's so interesting, isn't it? Because as you said, that estrogen, we know estrogen's anti-inflammatory. We also know that estrogen is important for bone and muscle health and tendons and ligaments. And we're seeing now, particularly with the increase of women in competitive sport, that things like their menstrual cycle affect injury rates and things like that. So we know that there is intense, association between our female hormones and muscles, tendons, ligaments. But yet it's like there's this kind of cloudy wall that, you've gone through menopause, but that won't be the cause of your joint pain. It's like, what? Hang on. We've just established X, Y, and Z, and now we're going, no, it won't be that. It'll just be something, it'll be just, you've just got, an itis of some sort.
You've done too much. You're just getting too old. Exactly. It's very, very frustrating for women, I think, to be told that. And it is impactful. I mean, women saying that they're sore turning over in bed at night. I mean, normally we're taught in medical school, that's a red flag, something bad's going on here. But often there can just be this wonderful conglomeration of losing hormones. Not just that, it's the far-reaching effects of the whole metabolic effect, bones and muscles, yeah.
Absolutely. And one of the things you said earlier too is that, there's hormone receptors in every single cell. But the other thing that we see a lot of is that, all the hormones talk to all the hormones. And so at our neck of the woods where we are really interested in insulin resistance, we see the decline in estrogen increases insulin. Women start gaining fat around their middle. If they weren't insulin resistant in the past, they often become insulin resistant. Their visceral fat is inflammatory. It sends out all these inflammatory mediators, adipokines, that then also just add to that inflammatory load. And it's like, wow, we're just one giant bag of inflammation.
Absolutely. And I mean, we can talk to sarcopenia if you like. I mean, sarcopenia it's really only been, so what it means literally is muscle loss. And we really don't know enough about it because it's only been recognised as a disease entity since 2016, which is kind of scary. And, we know that muscles, like our bones, are dynamic entities, and they're not just for locomotion, they're not just for stabilising our joints, but they have, as you said, that metabolic thermoregulatory role as well. The amount of muscle mass we have actually defines our basal metabolic rate. So, that's the rate we burn calories at rest.
Yes, I like to call that where you lie around burning calories for free.
Feeling strong. It makes sense, therefore, like you said, that sarcopenia is associated with fatty liver, diabetes, cardiovascular disease, and possibly even dementia too. And the menopause transition itself actually causes loss specifically of skeletal muscle independent of aging, which is interesting because, again, they're occurring in tandem. And estrogen loss rapidly at menopause leads to reduced muscle protein synthesis, increased muscle protein breakdown. We are more sedentary around this time. I mean, pain, as we talked about, low mood, fatigue. I mean, often that's why women shy away from being as active as they once were, and they prefer couch and a bit of Netflix, because why would you do that in the middle of winter, over exercise? And, women are often told, just take it easy. You don't need to be moving so much. As you said, when we do exercise, Lucy, our muscles are less responsive to change. And that's often due to aging. So, yes, even my very active patients will say they pull up quite sore from the gym. Our nutrition, as you said, I mean, we don't eat enough protein. We're craving more carbs and sugar. That's the insulin resistance, the change in gut microbiome, more inflammation. So, yes, there's this wonderful vicious cycle that's set up. And that's why when women come into us, they're broken and they find it hard to lift themselves out of that place, I think, because it's become this vicious cycle. And it's not just one thing. There's obviously this catalytic menopausal event or perimenopausal loss of hormones, but it's many factors. It's multifactorial. Like everything, as you said, it's all communicating together.
Yeah, and I think there's two things in that. One is that means that you often need a couple of things to improve the situation. There's no magic bullet. And as you know, and I know you advocate, we're big fans of MHT or HRT as it used to be called. And
I still call it HRT.
Yeah, I know, because you say MHT and people don't know what you're talking about. But either or, the thing that I think is, and it can sometimes be the circuit breaker, so that you can use that and then suddenly you've got a little less pain, so you can then do your strength training, or you've got a little less, you're sleeping better, so you can remember to then do the shopping so that you can eat real food.
That's a very important point. I think that it's not always, for some women, and it's actually less than I would always see, because there is no magic fix for anything. We know that for weight or for menopause itself. Yes, HRT does actually help restore our levels to normal, and the flow-on effects are what are really important. What you do with that as well are really important. And that's why sometimes the catalyst needs to be HRT, because women cannot even entertain doing any of this without their hormones. And so, the other things that I like to talk about to women, particularly when we're talking about losing muscle, as you talk about, and you're better preaching at me about this, but nutrition and protein intake, they're the building blocks of muscles. I mean, whether you're omnivorous, you're vegetarian, you're vegan, I think we know the Mediterranean diet has been shown to support muscle health and sarcopenia, and really high protein is important. Really high quality protein is important. So
yes,
as you say, always, food is medicine. Good lean meats, fish, nuts, eggs. I think a guide for women is 1 gram of protein per kilogram. This is post-menopause. 1 gram of protein per kilogram of body weight daily. And that's probably more than you or I or, most of us eat. So it's actually been...
I'm pretty good at hitting that macro now. But, yes, it's something that you have to learn to do. And people struggle because it's very filling, which is great. Again, I always go, great, how amazing to be able to eat, like we're telling you to eat more of something. And for decades, women have always been told to eat less.
Put stuff in, don't take it away. I mean, that's what I say to my patients as well,
Yeah.
Yeah.
Yeah, crowd out the junk is a great, it's one of Dr. Mary's favourite sayings, particularly around kids, because, kids are attracted to shiny objects, and we all know that junk food is marketed to children. And, but if you can crowd out the junk, then they're less likely to overconsume it. So it's interesting. So with the women that you see then, the type of advice you give them for muscles, because I think just taking a step back again is that, the women that you and I are seeing are women, 40s, 50s, 60s, give or take. And we've all dieted for such a long time and been on that diet roller coaster of losing weight, gaining weight, losing weight, gaining weight, being good, whatever that means. And now as part of that, our inner, I guess, vision has been that we need to be small and thin. And the sentence that I used to say in my head was I didn't want to bulk up at the gym, You didn't want to get too big. And
that's what we were told, weren't we? I mean, it's like the Olivia Newton-John, let's get physical, the little weights, do little movements. It's a real about turn, isn't it?
Yeah. And now we need to know that actually being strong is good, that being strong is feminine, whatever that means.
Correct. That means different things to different women.
People, yeah. And that we don't need to be small or little or tiny or diminutive or whatever other adjective has been to describe us as humans in order to be an acceptable woman.
Correct. Studies have shown that increasing resistance training is really important, not just for our muscles, but for our bones, because that's extremely important for later life. I see, there's a lot on social media, and there's a lot of people doing a lot of posing at the gym, lifting heavy weights and showing their beautiful sculpted bodies, which is, inspirational for some. But for that woman, a lot of the time that we see, it can be quite overwhelming. And I think, I like to say just start off with small little habits. Just do something, move a little bit. Lift your shopping bags, a few more repetitions, take the stairs, ride your bike to work. If you don't do it every day, that's okay, but start somewhere and build up. I mean, if you're not sure, if you've had injuries before, get help from a physiotherapist or an exercise physiologist. Not everyone loves the gym, but really the key is finding something that you love. And midlife is a really important time to start doing these things, start building small habits. I was not a natural exerciser, but learning that actually pain is often treated with exercise and movement and weights is quite a revolutionary thing, because if you pair that thought, if you think pain relief, also endorphins, really is a powerful motivator, I think, for women.
Yeah, absolutely. And I use the mental health component of exercise to get me going, because future me, current me sometimes doesn't care about future me. So current me, I need to bring it back to what does current me need? And because when I swim, which is helpful for lots of things, not helpful for bones, but we can talk about that in a minute. But it's the contracting of muscles that increases those myokines, which is then talks to your brain and basically improves your mental health. So it sounds weird, but you contract your muscles and you are happier.
Absolutely. And I know that your podcast is a lot about weight, and, our patients do, and women do, concentrate on their weight, not just for vanity's sake, but for health's sake. And as we said, losing skeletal muscle, we don't realise that actually contributes to our weight gain. And so also coming at it from, patients will say, I'm eating really well, I'm doing everything that you're saying, I'm putting all the protein in, but I'm not losing weight. Well, if you can actually change, if you can build some muscle, our bodies are so dynamic, if you can actually build some muscle, that will help with your insulin resistance. That will help, as you said, with your mental health, which will help with your motivation, which will help you get back to the gym. And so undoing that vicious cycle to a positive cycle.
Yeah. We call it spiraling upwards.
Spiraling upwards, yes.
And this is, do you know, one of the things I think you just touched upon there too is that whole body composition. And this is what drives me bananas. And, it is the hill that I will die on, which is when people tell women to cut their calories, or they'll go, based on your height and weight, this is how many calories a day you should eat to lose weight.
Very archaic. Very, very archaic.
So archaic.
Input, output, no. No.
So simplified, and they will, and because it sort of promises this simplicity, people are attracted to it. And because initially, if you do reduce your oral intake, your calories, your food, whatever you want to call it, the number on the scales may well go down. But that doesn't mean that you've lost fat. It doesn't mean that you've improved your health. And it is unlikely for that number to stay down.
That's right. I'll tell you an interesting sort of epiphany I had actually a few years ago, if I may. As you said, we're all taught that we need to be, very slim and small and diminutive. And my body's never been that. So part of, I think accepting who we are is part of our ethnicity and our genetics. And it wasn't until, so my ancestry is Sri Lankan, and I went to Sri Lanka for the very first time in my life about 6 years ago. And I saw this sort of cultural dance where they were doing amazing acrobatic flips and jumps and amazing displays of strength. And I noticed, I was like, these people, they're not diminutive. These women are not tiny. They are strong. And my body, and I realized that is where my genetics and my body shape comes from. So often within our own genetics, we have to accept, and we know there's lots of interesting, genetic drivers for that, but accepting our body for where it's at and composing it as such. So, we will lose and gain weight, put muscle on in different areas, genetically, ethnically determined. So accepting that, I think, as we get older is really important and part of how we harness the best out of our bodies.
Oh, absolutely. Like 100%. I wrote a blog a few years ago now, which I probably should rename because it's called Self-Love and Whippets, which is not a very searchable term, so people don't really go looking for it. But what it was drawing a comparison basically to the care we give to our dogs. And, as a dog lover, I have 4 dogs. They're all different shapes. I love them all equally. I look after them well. And I don't want them to change. I don't want one dog to be the same as the other dog. One's a Kelpie, one's a Border Collie, and 2 are little white fluffies. And somehow in human aesthetics, we've decided that everybody should look like a whippet. And we can't. We aren't. And we don't need to be.
That's right. And sometimes that whippet will think it is as strong as a Ridgeback. And it probably is, even though it has tiny ankles. And that's the thing. I think wherever your body's at, you can still achieve the same outcome as well. I remember that blog that you wrote, and I loved it because I love dogs as well. And that is an amazing message to get across to humans in terms of our body acceptance.
Yes, I think we need to hear it a lot because, again, women our age have internalized for decades that be a bit smaller, be a bit quieter, be a bit less. So, yeah, definitely continuing to hear that. So the summary for the muscles that I'm hearing from you then is that, yes, there are musculoskeletal, or there's certainly muscular issues that are often unveiled around that perimenopause time.
Even earlier, possibly, actually. I think these things even occur. So actually we peak, our bone and our muscles peak in our 30s, even before, when we even are cognizant of what's going on. And we start to lose it from then. Yeah, so it's actually, for younger women listening, something that we need to address earlier.
Yeah, it's like compound interest. People often go, I wish I'd started my super a bit earlier, or I wish I'd started, do start as early as possible, build in good habits that become easy. We wrote another little post just not that long ago called 5 Ways to Increase Your Strength When You Haven't Got Any Time. And so the first little tip was to stand on one leg when you're brushing your teeth.
Yes.
So everyone, most people brush their teeth twice a day for roughly 2 minutes. So if you can get into the habit and extend it out to 1 minute each leg, that's a really good tip for balance,
strength,
glutes,
proprioception.
Yes, all the things without taking any extra time or costing you any money.
And then you can challenge yourself by closing your eyes, brushing your teeth.
Oh, yes. Yeah, absolutely. Yes. Don't do that until you're really confident. And then we did one where if you're boiling the kettle, which again, lots of us still boil a kettle, making cups of tea or whatever, to do some sideways steps, because we spend a lot of time walking forwards.
That's right.
And we don't spend much time sidestepping. We then said when you get out of bed in the morning, instead of sort of just lolling out of bed, if you spin round, put both feet on the floor, stand up from your bed without using your arms. And if you find that easy, just do it 10 times. It will take you like 10 seconds. Or do it every time you get up out of a chair or off the toilet.
Yes.
You can fit it in without actually somewhere. Yeah. Every time you get out of the car. But unless you're conscious or mindful, you don't. Humans are so interesting. Not only have I got 4 dogs, we also have 3 cats. And I've noticed that all the pets, when they get up and they'll stretch.
Yes, they do.
They stretch, downward dog, cat arch. They do all of that. And we just get up and walk. Yes,
and wonder why we're so stiff.
Absolutely. Yes, so many things that you can do. The power of small steps, little tiny things that you can add in that over time, compound interest, make a huge difference to your well-being. Gorgeous friends, we are coming back next week to talk about bones. This has been such a great chat, and we've just gone on and on about the muscles, which is wonderful. And what we're going to do is revisit this conversation next week. So I would love for you to join us, where we will be talking about all things bones. Sunita, I'll see you next week.
See you next week.
The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualised medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.